Hello and welcome to the Penn Medicine Metabolic and Bariatric Surgery Program's patient information session recording. Thank you for taking the time to listen to this today. We're excited to have you with us. My name is Colleen Tewksbury. I am the Bariatric Program Manager and also a dietitian by training and conduct research within the program. So we're happy to have you here and hoping that you'll be able to get lots of good and helpful information from this session. We are going to go over a lot during this recording. The goal of this time period is not for you to memorize every single thing I review. It's really to give you an idea of what you can expect if you were to choose to seek bariatric surgery or weight loss surgery as your treatment option, as your treatment choice for severe obesity. It is not for you to know every single part of this process. It's really just to give you an idea of what you can expect if you were to come into our office and start this process. Uh, we will go over each and every step generally as you come through. If you decide that this is the best choice for you, we will repeat each of these items multiple times throughout the process. This is really just to give you an introduction as to what you can expect and for you to decide whether or not this is the best option for you. So our program specifically, we are one of the longest standing programs in the Delaware Valley. We have more than 20 years of experience in performing bariatric surgery, and we perform about 850 procedures every year. Now, we don't say that as a woohoo, look at us, we're a high volume center. We actually throw out that number because studies have shown the higher the volume, the more cases, the more surgeries an institution performs each year, the lower the rates of complications. And that actually holds true for our center as well. It makes sense. If you go to a center where this is what they do day in and day out, and you're seeing subspecialty clinicians, you would expect to have lower rates of complications. And that's exactly what we end up seeing in our program and what we try to offer. We have multiple awards and certifications and accreditations. Our staff is specialized. Everyone from the surgeon themselves, including the dietitians, the nurses, nurse practitioners. We have certified bariatric nurses. Our dietitians have advanced training in obesity treatment and weight management through the Commission on Dietetic Registration. And even our psychologists are bariatric surgery specific from the Center for Weight and Eating Disorders. So we provide specialized care for anyone seeking bariatric surgery. Additionally, because we are an academic medical institution, we do have access to the latest treatment options, and the vast majority of them are considered standard of care in our program, including what we call enhanced recovery, which is really just a term that's used to describe a protocol that really helps individuals heal faster, get home faster, and get back to life faster. So there are different components of that that we'll talk about, including even a reduced opioid pathway. So we have an app available for patients, and then we also offer robotic assisted surgeries. So now I'm going to briefly just review each of our hospitals, the physicians that operate at those hospitals, and where those physicians see patients for outpatient visits. So we'll start off with the Hospital of the University of Pennsylvania. That is the hospital at 3400 Spruce Street at 34th and Spruce in University City. We have 3 surgeons who operate at that location. Dr. Noel Williams off to the far left, Dr. Stephen Raper in the middle, and then we also have Dr. Chris Juman off to the right. So all 3 of these physicians operate at the Hospital University of Pennsylvania, and they see patients at the Perlman Center for Advanced Medicine, which is the outpatient center located across the street from the hospital at 3400 Civic Center Boulevard. Now, Dr. Williams and also Dr. Juman also see patients at our Valley Forge office, which is located right off of 202 in Berwyn. Next, we have Dr. Gary Corris he operates at the Penn Presbyterian Medical Center that is at 39th and Market in West Philadelphia. He sees patients at the Penn Medicine University City Building at 3737 Market. Then down at Pennsylvania Hospital. So Pennsylvania Hospital is located at 800 Spruce Street. We have 4 surgeons operating out of that hospital. We have Dr. David Wernsing, who is on the upper left-hand side of the photo, Dr. Matt Kirkland, who is on the lower left-hand side of the photo, Dr. Alan Shurik, who is on the upper right-hand side, and then Dr. Ian Soriano on the lower right-hand side. All 4 of these physicians see patients at our Penn Medicine Washington Square location, which is on the 20th floor of the 800 Walnut building. So it is the Penn Medicine building at 8th and Walnut in Washington Square. Dr. Shurik also sees patients in Cherry Hill at the new Cherry Hill building, and Dr. Soriano sees patients at Penn Medicine Mayfair, located at Cotman and the Boulevard in Northeast Philadelphia. So it may seem overly simple, but it is very important that we are all on the same page when we discuss what is obesity. How do we diagnose it? Before we start talking about how do we actually treat it. So this is how we diagnose obesity. It is not random. So we use a measure called BMI, or body mass index, kilograms per meter square. It's a ratio between your weight and your height. And it is not as if that is just a random number and we decided to round off by 5s for that BMI being associated with different diagnoses. This is actually a graph from one of the initial foundational studies defining where those diagnoses fall for healthy weight, having overweight, obesity, or severe obesity. So what you're looking at here, we have the different body mass indexes, or BMIs, going all the way up to 45 here, and then we have mortality ratio. So that is ultimately the risk of death. One is considered baseline. So what you'll see is that the higher somebody's body mass index, the higher the risk of death ultimately. So you'll see this as well with, let's say, blood pressure, any other chronic disease state. So the higher somebody's blood pressure, the higher the risk of death ultimately. So when we're looking to treat obesity, just like, again, I'm going to go back to blood pressure, we're looking to lower body mass index, or lower somebody's blood pressure, to lower the risk of mortality. That is ultimately what the goal of obesity treatment is. Now, there are other benefits. There are other motivating factors for individuals. There are other items to consider. But ultimately, the end goal, and what we're talking about from a clinical standpoint when you're coming in for obesity treatment, is to try to reduce body mass index as much as is feasible and safe for someone, to reduce the risk of mortality, reduce the risk of death. So how do we actually end up shaping up as a nation? Currently, about less than 1 in 3 is considered having a healthy body weight, or at very low risk of mortality. Low risk, or having overweight, body mass index of 25 to 30, about 1 in 3. And this was actually recently increased to about 40% of U.S. adults have obesity. This graph showing 36%. We are actually on the trajectory that if we continue with the trends that we've been seeing over the last decade or so, by 2030, more than half of all U.S. adults will have obesity. So we need good treatment options. We are all for prevention, and that is definitely a part of the treatment process, but we need strong and durable treatment options for individuals as well. So this is just a diagram ultimately showing that just about every organ system is negatively impacted by carrying excess weight. So that includes the lungs, liver, heart, right? All that additional weight can cause a lot of stress and increase the risk of developing other diseases. One that many individuals don't often think about is cancer. So the strongest risk factor for someone developing cancer in their lifetime is smoking status and whether or not they're a tobacco user. But the second strongest risk factor is actually someone's weight status. It's not something we often talk about, but especially when it comes to breast cancer, colon cancer, ovarian cancer, these someone's weight status actually is a very strong predictor and a concern for developing those cancers over their lifetime. Now, this is something that we don't want you to try and read. That's not the point of this. This is meant to be visually overwhelming. This is the obesity system influence diagram. Now, what this is, these are all the different points that influence weight gain or weight loss. So we have energy balance in the center, right? Calories in versus calories out. And then we have all the different points that impact that. If you were to go to the website for this diagram, it's interactive. You can hover over different components and you can see how they impact one another. So for example, we have this area here is food intake. One of these items is portion sizes right here. So you can hover over it and see if I were to change portion sizes, what would that actually impact? And how much of an impact would that have overall? So this is really just to show for all of these little tiny changes, how much of an impact do they really have on someone's weight status? We then have food production. So in here we have what is the price of the food that you're consuming? How easy is it for you to access healthier foods and healthier options? Over here we have physical activity. So that's your individual physical activity level along with your activity environment. So for example, over here would be is if you have a sedentary work schedule, if you're seated at a desk most of the day. Up here in the corner, we have social psychology. So one of the items on here is peer pressure. That is a really strong driver for many people in terms of how that impacts other items on this diagram, and also weight status as a whole. We have your individual psychology, including self-esteem is one of the items in here, an internalized weight bias as well. Then we have overall physiology. So your makeup overall and how your body functions. For example, we hear about ghrelin. Ghrelin is the hunger hormone. It's the hormone that makes you have that grumbling, burning hunger sensation. From a physiological standpoint, as you lose weight, the production of ghrelin increases. There are really only two things that cause that ghrelin level to no longer increase and possibly even come back down. One being surgery, which we'll talk about, but the second is gaining weight. So as somebody loses weight, we expect them from a physiological standpoint to get exponentially more hungry as they go. There are ways to be able to try and mask that hunger, but from a hormonal standpoint, the body is built to do that. Surgery is something that can interrupt that process. Then we have someone's individual physiology, ultimately looking at genetics. The strongest risk factor for someone developing obesity once they get into adulthood is actually what was their mom's weight status at the time that they were pregnant with them and then also throughout their lifetime. How much of that is genetically driven versus learned behavior, we can measure to an extent. We expect that to be about 30 to 70% of somebody's weight status. So it's not determinative. It doesn't mean that if someone's mother has overweight or if someone's mother has a healthy weight, they're automatically going to have the same weight status, but it's a really strong predictor and influencer of what someone's weight status will be when they're older. So all of this to say, weight gain and weight loss is not as simple as how much you eat or what you eat and how much you're moving. It is much more complex than that. So the development of obesity is extremely complex. We need to have just as complex, if not more so, a complex of a treatment option available to really be able to make an impact overall. So how do we actually treat obesity? This is one table that summarizes probably a 800-page textbook that we give students on how we treat obesity and weight as a whole. So across the top, right, each column is a body mass index or BMI category. On the left hand side for the 3 rows, we have the 3 different options or buckets that we can pull from for treatment. There are different variations for each of these groups, but they all funnel up to one of these 3. So first being diet, exercise, and behavior therapy. So what do we mean by that? That is not just seeing a dietitian once a month. That is actually very specific and intensive. So the gold standard is seeing a dietitian or a behavior change specialist in some circumstances, depending on the treatment option that you're looking at, for once a week for 4 weeks, and then once every 2 weeks for the following 5 months, and from there once a month. It typically ends up being 14 times initially. Most individuals do not receive this level of treatment because most insurances do not cover it. But that is considered the gold standard of diet, exercise, and behavior therapy. We also call it intensive behavioral therapy. Similar to if you were to see someone for mental health care treatment, we wouldn't expect to have great outcomes if you only saw them once a month. Similarly, for if you were to look at diet, exercise, and behavior treatment. So the more intense, the better the outcomes. We expect someone with that treatment option to lose about 5 to 7% of their total body weight. So if someone weighs 300 pounds, we'd expect them to lose maybe about 15 to 21 pounds, and that would be considered a great outcome. That's clinically significant. We would see improvements in blood pressure and blood sugar and cholesterol overall. But for most individuals who are seeking weight loss treatment, that is not enough weight loss for them. That is not what they're looking for. And it's also not enough to really bring down BMI significantly for someone with a body mass index of 27 or higher with a weight-related condition, or if they have a BMI of 30 or higher. That's just not enough weight loss. We wouldn't expect diet, exercise, and behavior therapy to be able to provide more than that. So that is when we start talking about adding on weight loss medications or anti-obesity medications. There are 6 FDA-approved ones on the market. Again, the challenge is for most individuals that most of them are not covered by insurance. But if you were to seek this treatment option, we would expect it to bump up weight loss to about 7 to 10% total body weight loss. So that would be more like 21 to 30 pounds for someone who weighs 300 pounds. Again, if someone weighs 300 pounds or if they have a body mass index of 35 or higher, that means statistically or mathematically they have at least 100 pounds to lose to really bring down their body mass index of excess weight. So 7 to 10% total body weight loss is not enough for those individuals in most circumstances. Many people are looking to lose more weight than that. That is when we start talking about surgery. So surgery, depending on the surgery treatment and also the individual, typically provides anywhere from about 1/5 or to 1/3 of someone's weight loss, total body weight loss. And is significant and durable. We expect it to have durable weight losses for an extended period of time and be able to really provide robust treatment for individuals. So that is recommended for surgery is recommended for individuals with a BMI of 35 or higher with a weight-related condition or a BMI of 40 or higher. Now, many times, and I'm a dietitian, we hear this, diet and exercise, that's where it's at. That is the foundation of everything that we do. But for someone who has a higher BMI, it's just frankly not enough, right? It only impacts certain parts of that diagram, of that map that I just showed you. We only expect it to provide so much. So one study out of the UK actually found that the likelihood of an individual with a body mass index of 35 or higher getting to a body mass index of 25 or below is potentially as little as 1 in 1,300. So the idea of diet and exercise, you can do it, is not only not effective treatment. It's borderline unethical to tell someone that that's the best option for them when we know that there are safe and effective treatment options available for people. Now, the challenge out of that is that when it comes to surgery, only about 1% of those that are eligible actually receive surgical treatment. Same thing for the anti-obesity medications, the weight loss medications. Only about 1% of those that are eligible actually end up receiving them. So there are a lot of misconceptions around both treatment options. We're going to go through them and hopefully be able to clear them up and answer a few questions for you as we go through today. So, who's a candidate for surgery? This is primarily dictated by insurance if you're going through insurance, but overall general guidelines are if someone has a body mass index of at least 40, or if they have a body mass index of at least 35 with a weight related condition like sleep apnea, diabetes, hypertension. Most insurance companies require medically supervised weight loss prior to surgery. We will talk about that. We consider that we call that medical weight management in our program, and I'll talk a little bit more about that in a little bit. We have all of our surgeons are specialized in bariatric surgery and members of the American Society for Metabolic and Bariatric Surgery. They have to be dedicated and experienced in bariatric surgery per insurance guidelines. We have that in spades here. Additionally, for a multidisciplinary team as well. And it's important to keep in mind that this is chronic disease treatment. Obesity is not a one and done treatment. Lifelong follow-up is required. I'm going to come back to hypertension. You wouldn't go to a physician, get a medication to treat high blood pressure, and then never go back again to make sure that it's working properly and doesn't need to be adjusted. Same idea with obesity treatment. Lifelong treatment is recommended, if not required. So the expectation is that this is a relationship lifelong with a obesity specialist if you were to pursue bariatric surgery. Okay, so what can you expect at your first visit? At your first visit, you'll meet with one of our nurse practitioners. They will review all of your medical and surgical history and learn everything about you and make sure that we have it in our electronic medical record. They'll do a physical exam and then they'll review any of the testing that will be needed prior to surgery. Some of this is required by insurance, some of this is required by our program. It is all meant to minimize any risk at the time of the operation, and hopefully if there is anything to be flagged, to flag it beforehand. So as an example, an upper gastrointestinal series is a test where you go to a radiology suite. It's called a fluoroscopy suite. It's basically a fancy x-ray machine, and you drink this substance called barium. And then the radiologist will take a series of quick x-rays, quick pictures as you drink that barium. And what we can actually see is if there's any abnormalities in your stomach that we need to address. The last thing we want is finding those when you are in the middle of an operation. So even though your insurance may not require this test, this is something that we want, that we require as a program to make sure that we are flagging as much as possible and making sure that we are reducing risk as much as possible to ensure you have a safe operation. So the nurse practitioner will review each of those with you at the time of that first visit. Then you'll also meet with our dietitian. The dietitian will do a full nutrition assessment. Then they'll review what's recommended for before surgery. They'll review what your insurance requires in terms of what we call medical weight management. For a timeline, it could be anywhere from 3 to 6 months of this preoperative counseling period. They will also review the requirements for support group attendance and then talk to you about our psychological consultation. For that, there's a $275 fee due at the time of that psychological consult that not all insurance plans cover. And so the dietitian will review whether or not you will be responsible for that. Most psychological consultations are not until at least 2 to 3 months into the process, so it will not be right out of the gate if you are responsible for that fee. And it is important to keep in mind if you go to certain locations, specifically our suburban locations, some of the equipment does have a 500-pound weight restriction. So if that is a concern for you, please call us so that we can coordinate your visit beforehand, and make sure that the equipment is available and we are able to best coordinate your visit ahead of time, or have you come for your visit at a different location to best accommodate you. Then at that first visit, you'll also meet with the surgeon. You'll talk about your surgical options. If you are both in agreement, and you both decide that it is appropriate to sign consents at that time, you will sign a consent at that time period. But then you will meet with either our front desk or one of our administrative assistants to schedule testing and your medical weight management visits. We'll provide you with our direct contact information, all of our direct phone numbers for both scheduling and also clinical questions. After that first visit begins medical weight management. So that medical weight management is a series of monthly visits, anywhere from 2 to 6, depending on your insurance, with a nurse practitioner and a dietitian. You see both clinicians at each visit. The whole point of this time, it's a period of preparation. It's your time to start to practice some of the changes for that will be coming with surgery, attend support group, and also complete the testing that is required prior to surgery. Now, it's important to keep in mind that just because someone meets the minimum number of visits or minimum amount of time that their insurance requires does not mean that we are automatically going to go forward with surgery if it is not safe to do so. So, as an example, during this time period, we have individuals get blood work done, including a hemoglobin A1C. Hemoglobin A1C is, if you aren't aware, familiar with the test, it is a measure of someone's average blood sugar for about the last 3 months. If someone has a very high hemoglobin A1C, let's say of like 12 or 13, if you have heard of non-healing diabetic wounds, that also pertains to surgical wounds. If someone has a hemoglobin A1C that high, the risk of them not healing properly after surgery is very high. So if someone's blood work comes back that high, and that they are done with their insurance requirements, we will still work with them to get that hemoglobin A1C brought down before we will proceed with surgery. It does not happen often that we extend medical weight management. It is very rare, but in the cases that we do recommend it, it is because it is for safety. We will be very transparent, but it is important to keep in mind that if there are any concerns over whether or not it is safe to proceed, we will communicate that with you and do everything that we can to make your operation and your experience as safe as possible. Now, we will not schedule surgery until all of these components are done, all of your testing and your visits are completed for that exact reason. If you were to have your blood work done at your last visit and then it comes back that we need additional testing done, we don't want to have you have a surgery date and then have to take it away. That's not a great experience for anyone. And we do not have far turnaround times for scheduling out surgery. So it is not a concern as if someone were to complete medical weight management and then it's a 6 month wait to be able to actually have the operation. So overall, things move pretty quickly. But something to keep in mind, we will not talk about surgery date until all of your testing and medical weight management is complete. During medical weight management, one of the things that we'll talk about is substance use. So first one will be NSAIDs. So these are common medications that you'll see over the counter. It's a whole class of medications like ibuprofen, aspirin, and then also some of the anti-inflammatory items that you'll have as prescription items like naproxen. Even Pepto-Bismol has an NSAID in it as well. So these increase the risk of developing ulcers, so we do recommend stopping them prior to surgery and also after surgery. For at least 12 weeks, potentially never, depending on the type of medication and the frequency of use. Same thing for caffeine intake. Caffeine is a stomach irritant. It can increase the risk of developing an ulcer as well. Now, when it comes to ulcers, for any sort of gastrointestinal or stomach surgery, they can become catastrophic relatively quickly. So we get very concerned about them and try to reduce the risk of developing them as much as possible. So that also includes tobacco use. So not only does the use of tobacco, including any form of e-cigarettes, increase the risk of developing an ulcer, but also increases the risk of infection or mortality. So we do require that everyone be abstinent from tobacco use for at least 2 months prior to surgery. And then lifelong abstinence is recommended, of course. So we review during medical weight management substance use and smoking cessation as a whole. Additionally, for alcohol intake, so alcohol increases the risk of liver damage and then dehydration, malnutrition, ulcers, as we talked about, and also is associated with weight regain long term after surgery. So we do recommend that individuals abstain from drinking alcohol at least 10 days prior to surgery. And then after surgery, technically speaking, the national recommendations are lifelong abstinence. We are realists. If you are going to drink alcohol, we want you to communicate with us about it. Pick up the phone and call your dietitian. We do recommend avoiding alcohol for at least 6 months after surgery, potentially never drinking. Or never resuming alcohol intake on a regular basis again. This is something that we want you to discuss with the dietitian and really evaluate the risks for you individually and what's the best way of approaching this for yourself. Lastly, we have recreational drugs and then the abuse of prescription medications. These both increase the risk of a heart attack or a stroke around the surgery. So we do require 6 months of abstinence preoperatively, which may include, or for most individuals, include a urine screen and communication with, if they're within a pain management clinic, communicating with their provider through that pain management clinic. If someone has a medical marijuana card or if they're prescribed opioids on a regular basis, we would coordinate with that provider who is managing that treatment. Post-operatively, it is recommended, of course, to abstain from any recreational drug use or abusing prescription medications. Now, for women of childbearing age, having obesity in and of itself increases the risk of complications if someone were to become pregnant when they have obesity. So, higher rates of C-section, preeclampsia, gestational diabetes, birth defects, and also stillborns. So, during medical weight management, it is recommended to actively prevent pregnancy. And then, additionally, after surgery, we don't see the risk. Studies have shown that the risk of those complications doesn't really diminish until at least a year, potentially a year and a half, 2 years out from surgery. So we do recommend preventing pregnancy for at least the first 18 months until that risk has come down and individuals are weight stable again. Now, the challenge out of that is that weight loss and weight loss surgery almost immediately afterwards increases fertility. So the challenge of increased fertility, but having to actively prevent pregnancy is something that we want all women of childbearing age to be cognizant of and actively working towards preventing throughout the process. So your clinician will talk to you about this further at your visit for you individually, but something we want you to be mindful of. Now, once you are done medical weight management, we have all your testing, we've scheduled your surgery, we will have you come in for your final, what we call a history and physical. So we review all of your history and medical and surgical one last time. We do a one last physical exam and make sure that everything we have on file that we're handing over to the inpatient team is accurate. We'll also go over what you can expect and what changes you may need for those 2 weeks prior to surgery. We'll also have you complete pre-admission testing at the time of that visit. The other portion of that day is to attend our nutrition and nursing class. We have nursing come over from in the hospital and explain step by step what you can expect for your inpatient stay. And then the dietitian reviews the dietary plan as well one last time, including the diet for 2 weeks before surgery and the first few weeks after surgery. Now, we do not bill for your time with the dietitian. You see a dietitian at every visit throughout this process. Rather than bill at each of those visits, we do a one-time fee of $200. This is due at the time of the nutrition and nursing class. This isn't a fee for that class. It's really your general nutrition fee covering you to see a dietitian at all your visits. This fee is not covered by all insurers. At your very first visit, the dietitian will review whether or not you will be responsible for this fee, but it will be upwards of 3 to 6 months before this would be due, so you will have plenty of advance notice if this is something that you will be responsible for. Now, surgery itself. Surgery is really broken down into two different types: malabsorptive and restrictive, or restrictive. Just restrictive. So we have on the left hand side here a Roux-en-Y gastric bypass, which is both malabsorptive and restrictive, a sleeve gastrectomy in the center, and a gastric banding procedure off to the right. Gastric banding is very rarely performed at this point. If that is something you're interested in, we can have you speak to a surgeon about, but there are very few people who would be considered a candidate for this procedure at this point. First, we'll review a Roux-en-Y gastric bypass. So how this is performed: your surgeon creates a small egg-sized, and we mean egg-sized, pouch at the top of the stomach. They disconnect the intestines about a third of the way down, connect it at the top, and then connect it further along down the intestines as well. So instead of food going down the throat, down the esophagus, into the stomach, and then into the intestines, it goes down into this little egg-sized pouch that holds about 1 to 2 ounces in the beginning, and then through this connection point here, what we call the Roux limb, and digestion for most foods does not begin until it hits this point here, what we call the Y junction. So when you see Roux-en-Y gastric bypass, Roux is this technique, and Y, it looks like a Y, right? Gastric stomach bypass. We're bypassing the majority of the stomach. So how it is malabsorptive: no food or any intake touches the stomach or this first part of the intestine, so there is some malabsorption, about 10% of what someone takes in. But because of this malabsorption, many people can get what's called dumping syndrome. About 4 out of every 5 people who have the gastric bypass procedure report experiencing this. So that is after having anything very concentrated in sugars, that it causes shaking, sweating, heart racing, and doubled over stomach cramps within a few minutes of consumption, typically. It's really a blood sugar spike and then crash, simply put. So for many people, this can be a strong deterrent. If you know that if you have something high in sugar, it will make you feel ill. Let's say like cakes, cookies, candy, soda, juice. But keeping in mind that not everyone experiences this who has this procedure. 1 out of every 5 don't in the beginning. And over time, we expect someone's tolerance of those foods to become better and better. Now, one thing that we do see with a gastric bypass is that we see changes in metabolic effects. We actually see in most individuals that ghrelin, that hunger hormone, production of that hormone goes down after surgery. So someone's body is not screaming at them that they're hungry in the beginning for most individuals. But on the flip side, we also see a reduction in satiety hormones. So most people don't feel extreme hunger, but they also don't feel extreme satisfaction from a hormonal standpoint in the beginning. Over time, both those hormonal systems re-regulate, and there is some level of hunger and satiety, but we don't expect it to get to the same level for most individuals that it was prior to surgery. So something to keep in mind. Then we have the vertical sleeve gastrectomy. So how this is performed: your surgeon would remove about 7/8 of the stomach. So vertical, right? It's vertical. Sleeve, you're left with what almost looks like a shirt sleeve. It's a tube. Gas stomachectomy, removing it from the body. So once this is done, it's done. The majority of the stomach is removed from the body, and you're left with a sleeve or a tube that will hold about 2 to 3 ounces, so slightly more in the beginning. You're not bypassing missing anything. So there's limited malabsorption. We don't expect someone to experience dumping syndrome. But the stomach does help with breaking down certain vitamins and minerals and helping your body absorb them. So there is limited but some concern for vitamin and mineral malnourishment. That is something to keep in mind with this operation. But we do see similar changes in hunger and satiety. So, again, a diminishment of that hunger hormone ghrelin, but also a lowering of satiety hormones in the beginning. So, the benefit, but something that we want individuals to be aware of, that both sides of that coin occur typically for most individuals after surgery. Now, laparoscopic surgery. What is laparoscopic surgery? Laparoscopic surgery, as opposed to open operation, is where your surgeon creates 5 to 6 small incisions, each of these black dots here representing where they would typically be placed, and they use those incisions to insert tools to be able to perform the operation, along with a scope, a camera. So the benefit out of this, each of the incisions ends up being typically less than 2 inches in size, most even smaller than that. And the benefits of laparoscopic surgery are typically shorter hospital stay, faster recovery, lower rates of certain complications like infection or hernias long term, or even for possibly some reduced risk of developing blood clots long term as well. So lots of benefits to having a laparoscopic surgery. Why does this matter? Well, laparoscopic surgery is the approach of choice for bariatric surgery at this point. So this is showing that more than 95% of bariatric surgeries are now performed laparoscopically. And why does this matter for you? Reason being, if you were to talk to someone who had bariatric surgery, let's say 15, 20 years ago, there's the possibility that they had a very different experience than you likely would. We have advanced significantly when it comes to the approach and the safety of bariatric surgery, and laparoscopic approach is really the primary driver of how this operation has become so safe. So how safe is it? What are the early risks? So when you sit down with your surgeon, they will review with you risks for after surgery and whether or not you may be at higher risk for one complication than someone else. But generally speaking, looking at this group of individuals, so we're looking at over 130,000 surgeries that were performed in North America back in 2016. In the first 30 days, 0.8% of them experienced some form of non-life-threatening complications of a urinary tract infection or a wound infection. Potentially life-threatening occurred in 2.5% of those individuals for these operations. So that would be like a deep wound infection, a leak, bleeding. A venous thromboembolism is a blood clot. A pulmonary embolism is a blood clot that travels to the lungs, or pneumonia. So these are all things that can be treated, but need to be treated early, if not could be potentially life-threatening. For life-threatening events, that was seen in 0.3% of individuals during this time period, so that includes cardiac arrest or respiratory failure or even a stroke, and mortality being the result in 0.1% of cases overall of surgeries. Now, for especially the life-threatening items and then higher rates of mortality, we have pretty strong clinical predictors as to who's at higher risk of experiencing a potentially life-threatening or a life-threatening complication after surgery. So if you are someone who has one of those risk factors, we would discuss that with you one-on-one and really talk about what your best options are and how you can minimize risks as much as possible. But overall, the complication rates of bariatric surgery compared to other operations are considered as safe, if not safer, than other elective procedures, and is typically rated as the safest gastrointestinal surgery that someone can undergo, second to an appendectomy or having your appendix removed. So your surgeon will talk to you about these one-on-one. Now, they will specifically go over each of the potential complications or risk factors. But one thing we want you to keep in mind is that we also have protocols to help reduce these risks overall. And most of them actually involve you being an active participant in your care and helping us help you reduce these risks as much as possible. So, for example, for urinary tract infections, this is more of an operating room item. We avoid catheters as much as possible. For wound infections, we have everyone do a prep wash the night before surgery and talk about how to care for your incisions to prevent them from getting infected after surgery. Your surgeon will review how they assess for a leak, but we also provide specialized training for all of our clinicians in the emergency rooms and also our clinicians in the clinic to identify any leaks early. For thromboembolisms, right, blood clots, and pulmonary embolisms, blood clots that travel to the lungs, uh, we recommend that everyone get up and get moving immediately after surgery. We have compression devices, and then also for those at higher risk, they may be sent home on injection medications like heparin or Lovenox, typically Lovenox, to help reduce the risk of developing a blood clot in the first few weeks after surgery. Pneumonia, we have incentive spirometer use, which is that breathing apparatus that many may have seen where you suck in to expand your lungs, and the little ball in the machine goes up higher, and you have to get in between the two lines or up to a certain goal. And we do extensive preoperative testing and get clearances ahead of time for anyone that's at higher risk of experiencing some of the more concerning complications for after surgery as well. Now, long term, this is a little bit more of a busy slide. Long term, some of the risks that can occur, a lot of them are related to behavioral items or nutrition or activity. So, narrowing and scarring of surgical connections, ulcers, hernias, small bowel obstructions. Many of those are complications can be related to dietary factors. So we do, well, the hernias more so for activity. We do have you meet with a dietitian at each of your visits to talk about these. Additionally, for excessive hair shedding or vitamin and mineral deficiencies, nausea and vomiting, or losing a lot of muscle mass. We have everyone meet with one of our psychologists as well to talk about any potential complications from a psychological or psychiatric standpoint. But one thing that I do want to point out that the surgeon will also talk about is that anyone that has experiences weight loss is at risk of developing gallstones, regardless of the method of losing weight. So that's something to keep in mind long term as well. Now, after surgery, it's recommended that everyone have a follow-up visit within 2 weeks of the surgery, and then again at 6 weeks, 3 months, 6 months, 12 months, then annually from there on out. After about 2 weeks, possibly at 6 weeks, if someone does not have any surgical concerns, we will have them just meet with our nurse practitioner who specializes in bariatric surgery, and then our dietitian. If you don't have any surgical concerns, we won't have you meet with a surgeon. We'll have you meet with a subspecialist for long-term obesity treatment and follow-up. Additionally, though, we do have support groups every month at all 5 of our locations to be able to help support you and supplement these visits as well. After surgery, the diet is progressive. It slowly increases from liquids up to solid food over about 2 months. And the whole point of this is not for weight loss, it's more so that your stomach can heal. We want you to heal properly and we want you to lose weight safely. So, part of that is typically keeping a food journal and keeping track of your intake. Actually, all individuals cannot physically eat enough food in the beginning to get in enough vitamins and minerals, nor enough protein. So supplementation is necessary in the beginning for both protein shakes and also vitamins and minerals. Lifelong vitamin and mineral supplementation is required, partially from a malabsorption standpoint for some individuals, but also because the portions are very small. It's very difficult to get enough vitamins and minerals after surgery and then also absorb it properly. Someone's dietary intake at 6 months after surgery is actually a very strong predictor of what their weight loss, what their weight will be 10 years out from surgery. So we know those early changes are really important for your long-term trajectory. So all the more important to make sure that you're following up with the dietitian. Now, exercise after surgery, the whole point of exercise, there are lots of benefits to exercise. Weight loss is not one of them. We do not expect someone to lose a large amount of weight through exercise alone. What exercise does during weight loss, it helps you hold on to more muscle mass as you lose weight and more bone mass. So when you lose weight, you don't just lose fat, you can also lose what we call lean body mass. So that's bone and muscle or fat-free mass. So as you lose weight, up to a third of every pound you lose can be that fat-free mass. If you are not exercising, uh, it can be on the higher end. If someone is exercising, you can minimize the amount of muscle and bone someone loses. So exercise is extremely important to stay healthy while losing weight and to help hold on to as much muscle and bone as you can and prevent osteoporosis. Now, on the flip side, it's also one of the strongest predictors of someone keeping off their weight loss long term. So studies have shown that individuals who ex- if someone is not exercising while losing weight and then during weight maintenance, the likelihood that they'll be able to keep off their weight loss without that exercise is less than 1%. So we like to say when it comes to weight loss, the people lose weight in the kitchen, they keep it off on the sidewalk. Right? You need both in the long term, but they each play their role. Uh, Exercise's role is not for weight loss. It's really to help you lose weight safely and to be able to keep it off long term. 1 year out from surgery, we expect most individuals to lose about 20 to 35% of their total body weight. In terms of resolution and improvement of different weight related conditions, your surgeon and also nurse practitioner and dietitian will talk to you about you individually, but we do see improvement or resolution for most of the major weight related conditions overall. Now, also after surgery, we see that individuals within 6 weeks of surgery report having an improved well-being and quality of life. But we also see extended lifespan. So this is a study that was conducted out of Sweden, looking at individuals who had surgery. That's the green line versus those who did not have surgery. They were matched, and what they had actually found was that those who had weight loss surgery, on average, outlived those who did not have weight loss surgery by about 7 years. This study was repeated actually in the US and similarly found that over a 12-year period, a 7-year, 4-month extended lifespan after surgery. So not only do people report having increased well-being and quality of life or improved well-being and quality of life, we actually see that individuals live longer after having weight loss surgery. 5 years out from surgery, the weight loss is durable for most individuals. So we expect individuals to be able to keep off their weight loss with a possible slight weight regain for 5 years out for both a sleeve gastrectomy on the left and a gastric bypass on the right hand graph. For overall weight loss, now specifically looking at the blue line here, this is Roux-en-Y gastric bypass going out 7 years. Like I had mentioned there, we do expect somewhat of a small weight regain, but overall weight loss being substantially greater than what we would have expected from other treatment options. Now, with that weight loss, we also see that diabetes and cholesterol levels and hypertension rates to decline with that weight loss over and maintain low rates or improvements in all of those markers up to 7 years out for this study. However, we do want to point out that significant weight regain is seen in 15 to 25% of all patients. Now, what we mean when we say significant weight regain, that is if someone were to regain weight and cross back over the 20% threshold of total body weight loss. Now, if you'll recall back to that initial table, what we expect for weight loss for diet, exercise, and behavior therapy is typically 5 to 7% total body weight loss, or adding in medications up to 10% total body weight loss. So that 20% is still significantly more than what we would have expected from other treatment options, but it's considered a significant weight regain overall. We see that in up to 1 out of every 4 patients who have surgery. Now, with that weight regain for those individuals, typically we also see that the weight-related conditions come back. Ultimately, when we look at those who are most at risk of regaining weight, prevention is key. The strongest predictor of someone regaining weight over time is their level of activity. So maintaining high levels of physical activity is important for long-term weight maintenance. Also self-monitoring, so that includes weighing yourself regularly, food journaling, staying connected with your office. Again, this is long-term disease management, and avoiding grazing. Many people are concerned about their surgery, quote unquote, stretching after surgery, or their stomach stretching back out. What is much more common, and what we end up seeing in studies and also in practice, is that individuals end up grazing. Their surgery is intact. They can maybe only eat a cup of food at a time, but if you eat a cup of food or a few bites every 10-15 minutes, stretch out over a long period of time, your stomach can empty out. You can slowly eat a large amount of food, and your surgery still be intact, by grazing. So that can be an unintentional way of having a large amount of calories in a single day, and something to watch out for long term. So ultimately, prevention is key. We do see weight regain in a minority of individuals who have surgery, but it is something that we want you to be aware of, and we want you to be proactive. Now, research. We are an academic medical institution. There is the possibility that you may be approached about participating in research at some point in time throughout this process. It could be as little as filling out a questionnaire, or allowing us to use your record in a research study. It could be as much as getting additional blood work, or completing an additional task, or interview. It is completely voluntary. Whether or not you participate does not affect your care here, but it is something that we'd ask you to consider if you are approached, and ask as many questions as you'd like. Now, why us? To wrap things back up, we are high volume, we are an experienced program, we have specialized staff. We are here to help you as an individual as you go through this process. Everyone has a different experience. There's no cookie cutter experience going through this process. So we're here to help treat you as the individual, and help adjust based on your needs throughout this process. But something to keep in mind is that we do specialize specifically in treating high-risk cases, and we are the center that other programs send patients to when things aren't going well. So this is what we do. This is what we've dedicated our careers to, and what we specialize in. And you get to benefit from that. So like I had mentioned, you get the individual attention from all of our clinicians to really help support you throughout your treatment process. Now, because we are at an academic medical institution, we have access to the latest treatment options that before they are available elsewhere. And some examples listed in here. Our most recent initiative is reducing opioid use before and after surgery, and potentially working towards almost limited to no opioid use throughout the process of surgery. So lots of exciting things happening, and you get to benefit from that if you decide to seek treatment here in our center. So your next steps. First thing is that you want to make sure that you know whether or not you have bariatric surgery coverage. For that initial visit, if you need a referral, making sure that you have one. If you have not done so yet, calling and making an appointment with our main access center at 215-615-7500. If you attempt to make an appointment through the My Penn Medicine portal, high likelihood it will instruct you to call us, since you are doing the online link version of this information session. Now, for that first visit, we want you to be prepared that it is a lengthy appointment. It could be up to 2 to 3 hours long. Now, reason being, you are meeting with multiple clinicians. You have your nurse practitioner, dietitian, surgeon, and then you're also setting up all your next step items at that appointment. So we know how challenging it can be to get to a Penn medicine facility. So we like to try and accommodate individuals for that first visit to make it as efficient and effective as possible, but that also can lead to a longer appointment because we're combining different components into one visit while you are in our facility. So please be prepared for that and plan ahead for it, and potentially bring a support person with you as well if you feel as though that would be helpful. Otherwise, if you have a question about next steps or any additional information that you may need, you can always call our main line 215-615-7500 and ask to speak with one of our coordinators, and we'll be able to help you from there. Thank you for your time, and please feel free to reach out if you have any additional questions. Otherwise, we hope to see you in our offices soon.